Understanding the difference between hypoxia and hypoxemia. Author Medina Regalia for Tarleton State University. Companion Animal Emergency Care and Pain Management class. So why is it important we as technicians are able to distinguish between hypoxia and hypoxemia? Firstly, we need to be able to accurately assess our patient's oxygen perfusion. Secondly, we must understand the effects of any underlying conditions the patient may already have. Being aware of all the symptoms of both conditions are essential to properly treat our patient. And lastly, we need to understand all three of these to also be able to watch for hypoxia and hypoxemia due to any concurrent treatments that they may be receiving. So let's start with the basics. Today we will discuss and explain what hypoxia is. We will also define and explain the causes of hypoxemia. Lastly, toward the end of our presentation, we will go over some overlapping concepts and cover some of the treatment options for both conditions. So what can cause these two conditions? Most of our patients typically include those that have laryngeal paralysis. Perhaps they have collapsing trachea, brachycephalic airway syndrome, pneumothorax, or felines with asthma, pleural effusion cases, also patients with diaphragmatic hernias, pneumonia or pneumonitis, patients in acute respiratory distress, rib fractures or rail chest, pulmonary contusions, or cases in which there is a mixed cause due to pulmonary edema. As you can see, our patients will probably range in age, breed, and species. Some cases that present with hypoxia and hypoxemia include all of these. First, let's discuss hypoxia. So what is it? How do we define it? Hypoxia is defined as an inadequate oxygen delivery to the body to effectively meet the metabolic demand of the tissues. This may be caused by inadequate tissue perfusion, metabolic disturbances, or lack of oxygen being supplied to the animal. Hypoxia can also be caused by a cellular level in which the cells within the tissue cannot effectively extract the oxygen being supplied. So when is hypoxia most prevalent? Typically during shock. Although shock in and itself is not a diagnosis, it is a secondary occurrence to internal or external factors. A patient may be in hypovolemic shock due to blood loss or fluid loss. Perhaps they're in obstructive shock from a physical obstruction like GDV or heartworm disease. Distributive shock may be caused by sepsis, anaphylaxis, or any condition that causes excessive vasodilation. And lastly, there is cardiogenic shock, in which the heart has impaired contractility, causing the heart to be unable to achieve normal cardiac output and eject blood. So what kinds of hypoxia actually exist? There are 5 major types that have been recognized and defined. The first one being hypoxemic hypoxia. This occurs when the patient has inadequate oxygen, with the end result being inadequate oxygen carrying capacity within the blood, which is secondary to hypoxemia, and there is decreased partial pressure of oxygen and a saturation of hemoglobin within the oxygen. The second is hypemic hypoxia, which is sometimes called anemic hypoxia. This occurs when the anemic patient has a deficiency of circulating hemoglobin that's reducing their oxygen carrying capabilities. Carbon monoxide toxicity is the most frequent cause of this condition, but occurs if there is less than adequate amounts of hemoglobin or there's dysfunctional hemoglobin present. The third type of hypoxia is called stagnant or circulatory hypoxia. This is usually caused by low blood flow and cardiac output, and it's sometimes referred to as circulatory shock. The fourth type of hypoxia is very unique. In these particular cases, there is adequate delivery of oxygen to the tissues, but there is a dysfunction within the tissues themselves, disallowing them to use the oxygen efficiently. A classic example of this would be a patient suffering from cyanide poisoning and can occasionally be caused by carbon monoxide toxicity. The last type has been identified as metabolic hypoxia. This occurs when there is increased cellular consumption of oxygen. Sepsis is a very common cause of this condition, in which there is increased need for oxygen within the tissues, causing a deficiency of available oxygen. So, what is hypoxemia? Hypoxemia is actually defined as the partial pressure of oxygen in arterial blood that is less than 80 millimeters of mercury. There are some cases that go below 60, and these are considered to be severe. Hypoxemia will result in the patient having a low pulse oximeter reading, and they may be possibly cyanotic. On screen, we can see a portable monitoring device that can be used to assess several parameters within our patients, including their oxygen saturation levels. To the right, we see a feline patient that is exhibiting signs of cyanosis. Hypoxemia generally occurs due to any condition that may interfere with the body's ability and capability to access oxygen during breathing and effectively then transport the oxygen molecules to the red blood cells. So hypoxemia can have a result of a multitude of conditions, but once diagnosed, their hypoxemia is going to fall into one of 5 categories. The first one is decreased fractional inspired oxygen concentration. It's very uncommon when this occurs, but the concentration of oxygen inspired is decreased and the patient's partial pressure oxygen will then also decrease. This most often occurs in high altitudes or when there is inadequate oxygen or there's been an interruption in oxygen delivery. Hypoventilation occurs when there is an increase in the partial pressure of carbon dioxide in the arterial blood. This excess carbon dioxide will displace the oxygen within the alveoli and decrease their partial pressure oxygen levels. We can find this most common in patients that are in the breathing room air or during general anesthesia. Oxygen supplementation may correct this condition along with monitoring with pulse ox. Ventilation or perfusion inequality of mismatch is the most common type of hypoxemia. In this case, the patient's ventilation and perfusion are not equal, resulting in hypoxemia. These patients may have airway disease, vascular disease, alveolar disease, or atelectasis. In these cases, treatment of the underlying condition is necessary to resolve their hypoxemia. And finally, there is diffusion impairment, which is a result of the patient being able to properly diffuse the oxygen through their tissues. Right to left shunting hypoxemia is due to the deoxygenated blood entering systemic circulation. Treatment for these patients may include oxygen supplementation, but usually surgery or some other intervention is absolutely required to ultimately correct the defect causing this kind of hypoxemia. So are these conditions similar? In short, yes. There's some overlap in these patients. How are they similar? In symptoms, they may experience shortness of breath, rapid breathing, fast heart rate, and some may be drooling. Also, it should be noted that hypoxemia can lead to tissue hypoxia, and conversely, hypoxia can develop into hypoxemia. Typically, the latter is due to high altitude or are drowning victims. So how should these patients be monitored? The main goal of monitoring these patients is to ensure that they have proper oxygenation, which involves their circulatory and respiratory system, proper ventilation, which assesses their respiratory function, and as well as their circulation, with a primary emphasis on cardiac output. So there are many different machines we can use for circulation. We can use the ECG, the ultrasonic Doppler, we can use oscillometric blood pressure measuring devices, or in the invasive blood pressure measurement. For ventilation, they can be on a respirometer. We can check their blood gases, and a capnograph also assists with this. For oxygenation, we would check their pulse ox and arterial blood gases. We should also be checking their temperature. You can use rectal, esophageal, or infrared. And in the cases that are under sedation, we should also watch their depth of anesthesia through the anesthetic gas analyzer and bispectral index monitor. So, do we have any treatment options for either one of these conditions? First of all underlying conditions should be evaluated and treated primarily. The patient should have their oxygen levels monitored during their whole treatment and in-house care, and supplemental oxygen should be provided. We have many ways of doing this, either through the flow-by machine, a mask, an oxygen cage, an oxygen hood, a nasal cannula, nasotracheal oxygenation, or intubation. We should also be watching their cardiac output to make sure that we aren't seeing any cardiogenic dysfunction. And the monitoring should be done every 15 minutes until the patient is stable and every hour thereafter. For further information on hypoxia and hypoxemia, here are some references.